Hello, everyone, and welcome back to the third episode of the IGCS Education podcast on malignant bowel obstruction, gynecologic cancer as a terminal phase of treatment rather than early treatment problem. Once again, I'm Peter Grant, Chair of the IGCS, or Co-Chair of the IGCS Palliative Care Education Committee, and I'm joined today by my co-moderator, Co-Chair, Dr. Anisa Mburu. Nice to have you back again, Nisi. I'm quite excited about today's episode. How are you going?
Oh, thank you, Dr. Grant. Yes, I'm quite excited, and hello to everyone. I'm really excited to hear what Dr. Bhatt has for us.
Yes, so look, it's great now. We should get started, and please welcome our guest speaker, Dr. Aditi Bhatt, who's agreed to talk to us today. And thank you for joining us. And could you introduce yourself to our listeners? Thank you.
Yeah, thank you, Professor Grant and Dr. Nisi. I'm Aditi Bhatt. I'm a surgical oncologist from India. I practice in the western part of India, and I've been treating ovarian cancer for more than 15 years now. Though I'm a surgical oncologist, the focus of my practice is peritoneal malignancies, and ovarian cancer forms a large bulk of it. And if you are treating ovarian cancer, there's no escape from malignant bowel obstruction. So I'm really looking forward to speaking to you today about this very important topic. Thank you.
So, Nisi, do you want to get on with the meeting and get us started?
Absolutely. So, to our listeners, again, we welcome you to the podcast. We're looking at the non-surgical management of malignant bowel obstruction. And to start us off, Dr. Bhatt, maybe you could just mention a few of the sites of obstruction when you're talking about malignant bowel obstruction, and then how we can proceed to manage them medically.
So when we are talking about malignant bowel obstruction, that is sort of an end-stage disease. It's usually multi-level. The small bowel remains the most common site. It is usually not one site, but more than one site in the small bowel itself. If it's ileal, proximal ileal, or distal ileal, that is a bit easy to manage, but the high jejunal obstructions, they do occur. And those are the tough ones because they produce a lot of symptoms. There could be obstruction in the left colon, but again, it would seldom be the sole site of obstruction. There will be partial obstruction in most of the patients at multiple sites in the small bowel. There could be duodenal obstruction, gastric outlet obstruction, but again, as isolated sites of obstruction, it's extremely uncommon when we are talking about end-stage ovarian cancer. And most of the times it's subacute obstruction, like if there is a malignant tumor rising from the small bowel or large bowel, it's complete obstruction. Or if it's a solitary site of recurrence, very rarely it could present as acute complete obstruction. But most of the times, malignant bowel obstruction is subacute, as in the passage of the lumen is not completely obliterated, it is narrowed. And that is why we are able to manage these patients for some amount of time with non-surgical treatments.
And now getting on to that, how exactly do you decide when non-surgical management is appropriate for a patient with malignant bowel obstruction? I mean, what clinical or patient-centered factors weigh most heavily?
So I think the first step in managing any patient is to review all the previous treatment records. I would go through what treatments the patient has had, what surgical procedures she has undergone, whether there's been surgery for recurrence, and study the scans in detail to look at the sites of recurrence and what is actually causing the obstruction. And my Personal, if it's a solitary site of recurrence, which again is very uncommon, then perhaps we can look at surgery. But when we are talking about end-stage disease, we will be treating more patients non-surgically than surgically. So my first approach to any patient, of course, would be to try non-surgical treatment. And surgery would have a limited role. So we essentially start with non-surgical treatment in most of the patients, unless there is one site of acute obstruction.
So do you look at some maybe lab test or patient's age or any other factors?
Yeah. So this is just the disease part of it. Of course, the patient has, how long standing the obstruction has been. If it's just a few days old, or the patient's been symptomatic for quite some time. Because if their intake is compromised, they'll be nutritionally depleted. Um, and a lot of times it's they are all right till the very end. They are not symptomatic and they suddenly become symptomatic. Or they could have some signs of obstruction that have been there for a few months. The appetite has slowly gone down. They are a little bit constipated, and so that is one important thing, how long standing the obstruction is. Because if it's coming on gradually and the disease is progressing, then again it points towards non-surgical management. A lot of times, of course, the site of obstruction would matter. If it's high jejunal, then they will have a lot of symptoms. But at the same time, if there are distant sites of obstruction, then you may not be able to help them much surgically. So it's the disease. It's the disease factors, where what are the sites of disease, how long standing the obstruction is, and whether the patient is fit to undergo surgery or not. If the patient has a performance status of more than 1, then those patients, um, uh, even if it's a last ditch thing, if the patient has been bedridden for a long time, then we are generally not able to help them surgically, because any surgical procedure is an additional stress for the body. So we should give a lot of importance to the performance status of the patient also while selecting them for surgery.
And so when we're looking at the symptom relief for this patient, how do you go about it? If it's pain management or if they have a lot of anxiety, how do you go about it?
The first step is to connect with the patient, to talk to them, get to know of all their symptoms, how long the symptoms have been there, and what is the one symptom that is bothering the patient the most. Sometimes you think she is vomiting, but she's not so concerned about the vomiting. It's the pain that is more disturbing. It's the loss of appetite that is more disturbing. So talking to the patient and taking the patient into confidence, assuring them that you are going to help them in some way. And then we start off with medical management, of course. There is, when there is subacute obstruction, when there is multi-site obstruction, there is tumor which is narrowing the lumen of the bowel, and it is associated with some inflammatory edema. So if you give rest to the bowel, you start steroids. That is the rationale for giving steroids. With non-surgical management, at least you can help the patient a little bit. So we ask them to, we give them dietary advice, we give them medications, antispasmodics, other painkillers, and antiemetics, and then other things like putting in a nasogastric tube or using octreotide. That'll be more individualized. But the basic would be to uh, uh, put them on a liquid diet, or make just put them on water. We don't, at least personally, I don't like to tell any patient that you cannot take anything by mouth, because there are so many secretions in the gastrointestinal tract already. So the dietary restriction, medications, steroids, and then other things depending on the other factors.
So I gather you are not one who believes that sort of nasogastrics are essential in all of these people, and I think the data certainly justifies that approach of being selective. But do we need to regard nasogastrics as still a prime part of their treatment, or should we be very conservative in the use of nasogastric tubes, knowing that there's data that says it complicates things, it's not pleasant, it has increased morbidity, it has an increased length of stay, and it has an increased association with sepsis, use of nasogastric tubes?
I agree with you that we should be selective. You could, again, it depends on the symptoms and the site of obstruction. If it's a high jejunal obstruction, if it's a duodenal obstruction, you will have to put in a nasogastric tube. Otherwise, the patient will have a lot of vomiting. And the idea would be to get it out as soon as the patient improves and the drainage from the tube reduces. So even if we have to put it in, we don't want to keep it inside for long, for all the reasons that you just mentioned. So yeah.
Do you have any protocols about the use of steroids, and how would you use them?
So I worked in different places, and in some of the hospitals that I worked, there were dedicated palliative care physicians. So when we had such patients, we refer them to the palliative care team, and they take a call on steroids. Once, as surgeons, we've said we are not going to do anything surgically, then the palliative care team takes over and they start steroids. We do not have a fixed protocol for giving steroids, but it is individualized. If in a patient, I feel that there is some scope of surgery, I would not like to give steroids to those patients, because it makes especially if you've given it for a few weeks, and we would be using high dose of steroids in these patients. If there is any scope of surgery, avoid steroids in those patients. Otherwise, we are more liberal with the use of steroids.
Good, thank you. Back to you, Nisi, I think.
Yes, there was something else that we'd wanted to know, because when it comes to parenteral nutrition in malignant bowel obstruction, there seems to be a lot of controversies around it. Where do you stand on its use, and what informs your decision?
So there are two schools of thought. One school of thought is that when you give parenteral nutrition, it'll provide some energy, some source of calories and nutrition to the patient, and it'll at least make them feel better in general. And the other school of thought is that you are feeding the cancer cells, and it is not going to help the patient in any way. For us, it depends on multiple factors. One is what the patient wants, because a lot of times when such a situation is reached and we tell the family this is the prognosis, they want to take the patient home and just give supportive treatment at home. Or there are cost constraints. And then there is another set of patients, that they want everything to be done. So they want TPN, they want all the drugs, all the interventions that are possible. So for those patients, we would use TPN whether or not we believe in it, because to give a sense that we are doing something to, whatever you can't say for sure it's not working. So that's how basically we decide how to give TPN or not. And if there is any scope of surgery, then of course TPN. If you are looking at surgery, if you think, then it's better to supplement with parenteral nutrition.
And on the same note, especially for patients who are terminal, they have MBO, and then we're talking about IV fluids. How much would you advise on them being given? There's some schools of thought that say that if you're going to give IV fluids, it has to be really minimal because their organs are shutting down, and so you risk of overloading the system. What are your views and experience on that?
So we try to encourage oral liquids and try to maintain as much oral hydration as possible if the patient's not vomiting. And for fluids, again, it's less than 1 ml per kg per hour over 24 hours, 0.6 to 0.7 roughly. That is how much we give. And sometimes for some patients who are able to retain some liquids or semi-solids, then we also time it, let's say give it over 3 to 4 hours a day. So the patient's not stuck with an IV line all day. So they are not connected to a drip, to a pole, and they are free to move about and more comfortable.
Thank you. And now for your patients, do you put them on any antispasmodics or antiemetics? And how much of it do you give them? And also, how do you balance the side effects with the symptom relief?
So we generally give as an antispasmodic, we use hyoscine butyl bromide, and that practically has no side effects. If the patient still has pain, we use a combination of opioid and paracetamol in a low dose. That's what we generally do for pain, and the painkillers per se do not produce too many side effects. We use pain patches also, the opioid patches, they help patients. And for the antiemetics, it is ondansetron. That is the first drug. We use 4 milligrams twice a day, and we step it up if required. And then we use the others depending on how the patient's responding to these drugs.
And do you find that there may be some new pharmacological agents or protocols that are showing promise? For example, use of gastrographin.
That's the thing about the use of these agents, that they are hygroscopic. And when you administer these agents, they will reduce the edema and they could temporarily relieve the obstruction. So if the patients developed malignant bowel obstruction for the first time, I think that's where all these non-surgical treatments will be most effective. If the patients got multiple episodes of obstruction, then as you go down the line, all these treatments become less effective. So yes, it's I think it helps anything that reduces edema it helps in providing relief of obstruction and symptomatic relief.
Dr. Bhatt, some of these patients with advanced recurrent ovarian cancer and the carcinomatous ileus also have a lot of ascites.
Yeah.
Do you think it's worthwhile doing paracentesis if possible? Is that an important factor in trying to help the gut recover or improve a little bit? Or do you think it's a waste of time?
I think if the patient's very symptomatic from the ascites, we have no choice but to drain the fluid to make the patient comfortable. I doubt, yes, it could help because if it's dense ascites and it's causing pressure on the intestines, then at least that component will be gone. But we need to supplement it with some protein infusion. We usually give albumin infusions depending on how much the patient can afford again. Because at this stage, a lot of our patients are already financially depleted. So
Yes.
a lot
And that
depends.
leads me to the next question. Some of the drugs that we commonly use in more affluent societies cost a lot of money overseas, and are there particular things like itreatide are not readily available in some countries or are very expensive? So do you routinely use that, or do you try protein pump inhibitors or other drugs to reduce gastric secretions and GI secretions?
So, yeah, I didn't talk about proton pump inhibitors because they are like a regular in the prescription. So we would be giving proton pump inhibitors to all our patients. They are quite widely available in our country, and we have a lot of local pharmaceutical companies, the generics that provide low-cost drugs. Octreotide, as such, it is quite freely available, and a lot of our patients are able to afford it. In the second, third tier cities, in government hospitals, in many hospitals, it's available free to the patients also. It has to be sanctioned. So it varies, we have not struggled so much with the cost for this.
Okay,
For the basic drugs. Yeah,
good.
but it could be a problem where you have to weigh in what to, what to spend your money on.
Okay, thank you.
Out one more thing in very brief, that is about the use of stents. One part of, especially if there is, because the sigmoid colon is lying there in the pelvis and you have the sigmoid obstruction or descending colon obstruction. Personally, I think it's not a great idea to stent these patients because the peritoneal disease, the bowel is, it's very difficult to predict how the bowel is going to behave. So I would be very reluctant to recommend stenting in these patients with malignant bowel obstruction. We have to be very cautious.
That's good to hear. Certainly, that's my experience too. Thank you.
It's very interesting. And I think now, as we wrap up, we've talked about how there's some countries that can't afford certain drugs, and our listeners come from various different economic status countries. And so, to sum it up, do you think that the palliative protocols for malignant bowel obstruction are standardized or evidence-based across institutions? And if you think there's some room for improvements, what are they?
I think it's best to involve a number of specialists in your own hospital or institution and develop your own protocol based on the recommendations, keeping in mind that for a lot of interventions, the evidence is for and against as well. And it's extremely difficult, to stick to evidence-based recommendations, even stick to your own protocols, because every patient is different. Their socioeconomic condition is different, their expectations are different, their obstruction, the disease is different. It's good to have a protocol, but knowing that you will not be able to adhere to it in every patient.
Absolutely. Oh, this has been very informative. Thank you so much, Dr. Bhatt, for taking the time to join us for today's podcast. I have learned quite a lot, and I'm sure the listeners feel the same. And
Thank
so, Dr. Grant, any last words?
Thank you, Nisi. I've learned a lot too, and thank you for your time, Dr. Bhatt. Yes, I hope we can do it
Thank
again.
you. Thank you so much for having me. It's been great
Won-
interacting. Thank you.
Wonderful. Thank you all, and thank you to our listeners. Tune in next time for our next episode where we will discuss surgical interventions. Our expert guest speaker, Dr. Glauco Bayoki, will share his insights on surgical procedures that will be very, very enlightening. Thank you all for listening.